and laser remote sensing of the atmosphere. He's founding director of Sunlight and Nutritional and Health Research Center, an entity devoted to research, education, and advocacy relating to the prevention of chronic disease through changes in diet and lifestyle. His primary mission is to identify and quantify risk-modifying factors for chronic diseases. He's particularly interested in UVB and cancer and infectious diseases, but also studied the role of dietary factors in disease risk. Please give a warm welcome to William Grant.
Thank you. I do not have any financial interest in a product or in my talk or with any companies offering grant money for the continuing dental and medical education program. I'd like to thank the organizers for inviting me. I spoke in New Jersey a couple of years ago, and you had another vitamin D talk by Cedric Garland in San Diego, I think a year and a half ago. So hopefully the vitamin D message is getting across. I do have funding from these organizations, the UV Foundation, the Vitamin D Society, Sunlight Research Forum, and Biotech Pharmacal. Today I'm going to discuss first the physiology of vitamin D, then the history of dental caries and solar UVB, also talk about periodontal disease, talk a little about some vitamin D and calcium supplement studies, then correlations between dental caries and periodontal disease and other diseases, and then sources of vitamin D. Now, vitamin D3, or cholecalciferol, is made by the action of ultraviolet D radiation on 7-dehydrocholesterol in the skin, followed by a thermal process. Solar UVB extends from 290 to 315 nanometers, and UVA from 315 to 400 nanometers. UVB comprises about 3 to 5% of the solar UVB in mid-latitudes and midday. Wearing sunscreen can block this and reduce the production of vitamin D. Now, vitamin D3 is converted in the liver to 25-hydroxyvitamin D, the circulating form of vitamin D. That's what you measure when you have a blood test. Then 25-hydroxyvitamin D is converted in the kidneys and other organs to 125-dihydroxyvitamin D, which is the active or hormonal form of vitamin D. Vitamin D receptors are activated by 125-dihydroxyvitamin D and affect gene expression. So the hormonal version of 125 acts like a key that goes into the vitamin D receptor. The vitamin D receptor can bind to chromosomes and affect maybe 200 types of genes, upregulating maybe 2/3, downregulating 1/3. There are different alleles for the vitamin D receptors. Some will be beneficial, some will not be beneficial. Vitamin D is stored in the adipose tissue. 25-hydroxyvitamin D is stored in the muscles, and along with 125-dihydroxyvitamin D circulates in the blood. Now, vitamin D2, or ergocalciferol, is made from yeast and is less effective than vitamin D3 and lasts less in the blood. However, MDs have often been able to prescribe that and not prescribe D3, although there are 50,000 IU units, capsules of vitamin D3 available now. Now, vitamin D3 has antimicrobial properties. The 125-dihydroxyvitamin D induces production of capsaicin and defensins, which have both antimicrobial and anti-endotoxin properties. These polypeptides have been found effective in fighting tuberculosis, pneumonia, septicemia or sepsis, oral bacteria, as well as the viruses such as Epstein-Barr virus, influenza, and rhinovirus. Remember about 100 years ago, people with tuberculosis would go to solaria. They would sit out in the sun and cure their tuberculosis. Well, researchers at UCLA finally looked at the mechanism and found it was the 125 interacting with the macrophages and inducing production of capsaicin that was effective. Vitamin D3 also has effects on inflammation. It affects immune cells as follows. It decreases proliferation of dendritic cells In macrophages, it decreases interleukin-6, IL-23, tumor necrosis factor alpha, and increases cathelicidin. In T cells, it stimulates its T helper 2 response, which increases IL-10 and decreases the Th1 response, such as IL-2 and IL-17. So if they're shifting from the Th1 to Th2, that's one of the important beneficial effects of vitamin D in reducing risk of some of the adverse effects of viruses, including induction of some of the autoimmune diseases. In B cells, there's decreased proliferation and immunoglobulin production. Now, the first, unfortunately can't see the slide here, but there was a paper from about 1865 reporting the tooth loss among Union Army members. And they found that it was from Tennessee up to Maine. And as they went higher in latitude, the conscripts had fewer teeth, which I think was probably due to lower amount of sunlight. This assumes that they all had the same dietary factors in those days. Now, there was work by May Bellenby in Sheffield, England in the early 1920s related to dental caries and vitamin D. Her husband, Edward Mellenby, conducted research to establish the role of vitamin D deficiency as a main cause of rickets. His wife, May Mellenby, studied the role of vitamin D in reducing risk of dental caries in the 1920s. In a study reported in 1924, a diet rich in eggs, milk, and cod liver oil and low in cereals resulted in fewer caries than diets with less calcium and fat-soluble vitamins and more cereals. In 1928, she and C. Lee Pattison reported results of another study in which children were given vitamin B2, and those children taking vitamin B2 had fewer caries and a higher degree of hardening of the enamel. The mechanism thought to explain the reduced development of caries in that study was increased calcium absorption and better calcium metabolism. However, she noted, the dentinal tubule may contain microorganisms. These, however, are apparently inactive or dead. Of course, the antimicrobial properties of vitamin D were unknown at that time. Now, I reviewed this historical literature in an open access paper at Dermatoendocrinology, and that can be easily accessed through PubMed. One of the other studies of, this was in the 1930s, I think it was a paper by East. He compared dental caries in 12 to 14-year-old males versus hours of sunlight per year in 4 U.S. regions. The dark region, they had approximately 5 dental caries per person, and that was where they had less than 2,200 hours of sunlight per year. And when they went up to 3,000 hours per year, they had fewer than 3 dental caries per person. So back then they were beginning to realize that sunlight had the ability to reduce the formation of dental caries. Now, I used to work at NASA, and this is a NASA data product from the Total Ozone Mapping Spectrometer, or TOM instrument. This is the DNA spectral UVB dose for July 1992. And what you see is that it's color-coded. The blue at the top has very low solar UVB in summer. The yellow and purple down in the lower left has very high solar UVB doses. Now you see it's not just a latitudinal variation, but it's a sort of asymmetrical. And the reason it's asymmetrical, it has 3 reasons. First of all, states in the west generally are at higher surface elevation than states in the east, so there's less atmosphere to attenuate or scatter the solar UVB. Second, the prevailing westerly winds push across the Rocky Mountains, and in doing so push the tropopause higher and make a stratospheric ozone layer thinner, so then there's less ozone to block the solar UVB. And thirdly, there's more aerosols and clouds in the eastern United States, so that's going to attenuate the solar UVB. So the asymmetry is very useful because it then allows one to see that the effect, make sure the effect is due to the solar UVB and perhaps the summertime UVB, whereas just a latitudinal effect could be due to wintertime UVB because then it's a solar angle and not the everything else that is important. Here is a map of dental health in the first half of the 20th century. A dental rank of like in Maine of 44 means very poor dental condition, whereas a dental rank of 5 in Texas means very good dental condition. And this was an average for, I think, veterans going to World War I and World War II. So if you look at that and compare it to the UVB map, you see there's a fairly good correspondence. In fact, again, I guess we don't have ability to show some of these figures, but, well, it's there, but it's hard to see. What I show is that the dental rank in the lower, those with poor dental rank have a linear slope up until about a value of maybe 7, 7.5, after which there's no change. So that's showing that they need as much vitamin D as produced in above about 7, 7.5 kilojoules per meter squared to protect against dental caries. Now, periodontal disease, I guess defined primarily by attachment loss and is more the adult version of adverse effects in the oral cavity due to low vitamin D. Dental caries happen more in youth, periodontal disease more later in life. And according to this paper in 2011, an emerging hypothesis is that vitamin D may be beneficial for oral health, not only for its direct effect on bone metabolism, but also due to its ability to function as an anti-inflammatory agent and stimulate the production of antimicrobial peptides, such as capsaicin. There are several mechanisms. Actually, there's the increased absorption of calcium and regulating of calcium metabolism, the antimicrobial properties, and reduced concentration of matrix metalloproteinases, which have been discussed by previous speakers. I think Boyd Haley discussed that. The matrix metalloproteinases want to dissolve the collagen. And we published another paper with Barbara Boucher in England asking, are Hill's criteria for causality satisfied for vitamin D and periodontal disease? Now, A. Bradford Hill was the president of the British Medical Society, and in his outgoing address to the organization, he laid down the criteria for causality in a biological system. These criteria include strength of association, consistent findings in different populations, a dose-response relationship, being consistent with science, and help to have mechanisms. Experimental verification is useful, such as randomized controlled trial. Analogy with other findings is useful. And you want to rule out confounding factors. Now, not all of the criteria need to be satisfied for one to claim causality in a biological system, but the more that are, the better. Unfortunately, in the United States, the Food and Drug Administration and the National Institute of Health work with a drug model, and they primarily will accept only evidence from randomized controlled trials of vitamin D. Unfortunately, the medical system has been, well, for many years, it didn't understand vitamin D. It thought that, well, since 400 IU per day reduces that's the amount of vitamin D in a teaspoon of cod liver oil, since that reduced rickets, then that's probably enough for any other disease. So, for example, for the Women's Health Initiative study, which cost about $500 billion, they enrolled thousands and tens of thousands of women and gave them 400 IU per day of vitamin D and 1,500 milligrams of calcium per day in the treatment arm. They found virtually no effect on any disease and essentially wasted the money. I mean, now they're going to repeat a study at Harvard, the VITAL study, where they're going to give people 2,000 IU per day of vitamin D and or fish oil and or calcium, but it's taken them a long time to learn that it takes more. So unfortunately, there are not many randomized controlled trials that show the benefits of vitamin D to the satisfaction of the Food and Drug Administration or the NIH. But if you use Phil's criteria for cancer, for cardiovascular disease, for dental caries, periodontal disease, then you can show that very likely vitamin D is the agent that's doing the beneficial work. These MMPs are enzymes that assist in the modulation of interstitial tissue by digestion of a supportive matrix, such as collagen, and MMP9 in particular is known to be present in large amounts in active periodontal disease. Higher plasma levels concentration is found in periodontal disease patients compared with healthy controls, and active vitamin D, that's 125 dihydroxyvitamin D, has also been shown to suppress the increase in MMP9 formation induced in white cells by tubercle bacilli as well as MMP3. Here's one vitamin D and calcium supplementation study related to periodontal disease. The total daily calcium and vitamin D intakes were 769 milligrams of calcium, 1,049 international units of vitamin D in the pig group versus 642 milligrams of calcium and 156 international units of vitamin D in the non-pig group. The clinical parameters of the periodontal health improved in time in both groups, but when the clinical measures were considered collectively after adjusting for covariates, the p-values for the effective supplementation were as follows. For baseline, 0.028, which is significant to the 0.05 or 1 in 20 chance that it's due to this chance. For 6 months, it's 0.03, and 12 months, 0.06. So this shows modest beneficial effects. Here's another study looking at the effect of vitamin D status on periodontal surgery outcomes. The vitamin D regulates calcium and immune function. This longitudinal clinical trial assessed outcomes of periodontal surgery and teriparatide administration in vitamin D sufficient and insufficient individuals. 40 individuals with severe chronic periodontitis received periodontal surgery, daily calcium and vitamin D supplements, and self-administered teriparatide or placebo for 6 weeks to correspond with osseous healing time. Serum 25-hydroxyvitamin D is evaluated at baseline, 6 weeks, and 6 months post-surgery. Clinical and radiographic outcomes are evaluated over 1 year. The placebo patients with vitamin D deficiency, that was serum 25-hydroxyvitamin D in the 16 to 19 nanograms per milliliter level, has significantly less clinical attachment loss gain and probing depth reduction than vitamin D sufficient individuals. Vitamin D levels had no significant impact on CAL and PPD improvements in teriparatide patients at 1 year, but infrabony defect resolution was greater in the teriparatide treated vitamin D sufficient versus deficient individuals, 2.05 millimeters versus 0.087 millimeters. So vitamin D deficiency at the time of periodontal surgery negatively affects treatment outcomes for up to 1 year. Analysis of these data suggests that vitamin D status may be critical for post-surgical healing. Now, periodontal disease has been linked to many vitamin D sensitive diseases. Some of the references are mentioned here, including many types of cancer, cardiovascular disease, diabetes, mellitus, and pneumonia. In many association studies, commonly accepted risk factors for periodontal disease, such as smoking, were included in analysis, but could not explain the association. So one question asked, does cleaning the oral cavity of plaque reduce the risk of disease? One study evaluated the role of periodontal pathogens in 50 hospitalized patients with hospital-acquired pneumonia compared with 30 healthy controls. Specimens of oropharyngeal aspirate, dental plaque, bronchoalveolar lavage, and blood cultured one or more pathogens in around 80% of patients. predominantly Staphylococcus aureus, followed by coagulase negative staphylococci, Streptococcus pneumonia, and Klebsiella pneumonia. C-reactive protein levels were significantly higher in patients than in the controls, and there was a significant correlation between serum and salivary CRP levels. Dental plaque biofilm may promote oral and oropharyngeal colonization of respiratory pathogens in hospital subjects. I think that the evidence for periodontal treatment, just cleaning the mouth of plaque, is mixed. Some studies find a benefit, some do not. Here's another study finding that oral microbial diseases usually arise from growth of opportunistic pathogens. Predisposing factors for oral infections are contact with pathogen carriers, impaired immune system, poor oral hygiene, and smoking. In chronic periodontitis, tooth attachment is lost as a result of inflammation and pockets form between the tooth and gingiva. Chronic periodontitis is associated with an increased risk for cardiovascular disease, pulmonary infections, and poor glycemic control of diabetes. This may be due to constant release of pathogenic bacteria and pro-inflammatory cytokines into the bloodstream. Accumulated evidence has strongly suggested that long-term effects of periodontal diseases can be linked to more serious systemic conditions such as cardiovascular diseases, diabetes, and complications of pregnancy. Especially a prevalence of coronary heart disease was found to be significantly increased in patients with periodontitis after adjusting for risk factors such as smoking, diabetes, alcohol intake, obesity, and blood pressure. Furthermore, various studies have shown that Porphyromonas gingivalis, a major periodontal pathogen, is able to exacerbate atherosclerosis following oral hematogenous spread due to the bacteremia. By P. gingivalis, endothelial cells activate and upregulate the various adhesion molecules, thus increasing likelihood of macrophage diapindus and subsequent conversion to foam cells, thus furthering atheroma progression. This was discussed in some of the earlier talks today. These findings likely indicate a tight relationship between periodontitis, periodontal pathogens, and cardiovascular diseases. Again, we have more of the same. Here's blood pressure and etiologic bacteria burden. This is showing that as the etiologic burden increased, both the hypertension prevalence increased, that would be from 55% up to about 75% for females, and from 40 to 75% for males, where also the blood pressure, systolic blood pressure increased from as low as 132 to 144 milligrams of mercury. Here's a study from Scotland which has very low vitamin D levels due to high latitude and lots of clouds. They used a prospective cohort design and data from the Scottish Health Survey. They combined data from surveys in 1995, 1998, 2003, and linked this to mortality records. Dental status was classified through self-reports of natural teeth only, natural teeth and dentures, and no natural teeth or edentate. Cox proportional hazard models were used to estimate risk of cardiovascular mortality rate by dental status adjusting for potential confounders. They had nearly 13,000 participants followed for 8 years. During over 100,000 person years, they had 1,480 cases of all-cause mortality, of which nearly 500 were from cardiovascular disease and 500 from cancer. After adjusting for many factors, the edentate subject has significantly higher all-cause mortality rate of increased by 30%, and cardiovascular mortality rate by about 50% compared to the subject with natural teeth only. There is no effect related to cancer in this case. If they look at just cardiovascular mortality, that in the fully adjusted model, edentate subjects had about a factor of 3 times higher risk of stroke-related mortality. There was a recent paper just published last week pointing out that antibodies to periodontal disease bacteria associated with pancreatic cancer in a very large European study. They also found that antibodies to beneficial oral bacteria are inversely correlated with the pancreatic cancer. And I submitted a letter to the editor suggesting that it's serum 25-hydroxyvitamin D concentrations that explain the link, that they were able to, there's evidence that the capsaicin induced by vitamin D kills off the pathogenic bacteria, permitting the beneficial bacteria live. And there's lots of good studies showing that pancreatic cancer is inversely correlated with serum 25-hydroxyvitamin D and solar UVB doses. One of the things I'm looking into now is a link between periodontal disease and adverse pregnancy outcomes. There's a large body of literature with over 1,000 papers listed at PubMed showing that periodontal disease during pregnancy is associated with low birth weight, premature delivery, gestational diabetes, hypertension, preeclampsia, miscarriage, primary cesarean section, et cetera, et cetera. So thus, the diagnosis of periodontal disease during pregnancy is a warning flag, very likely of vitamin D deficiency. I'm told by my British colleague that in England it's well known that pregnant women develop periodontal disease, and as a result, they're given free dental care. They don't think about the vitamin D yet. However, it appears that since there's good evidence that vitamin D does reduce the risk of periodontal disease. In fact, when I lived in the early 1970s, I lived in Berlin for 2 years doing a postdoc in physics, and I was doing all my work in the laboratory indoors and not taking supplements and not eating diet with high vitamin D. And in 2 years, I developed periodontal disease and had to have it treated when I returned to California. So even young people can get periodontal disease with lack of vitamin D. Now, there was a very, very good study by Bruce Hollis, Carol Wagner, and colleagues at the Medical University of South Carolina just reported last year. They had enrolled maybe 300 or so women in a study where they gave, starting at about the 12th week of pregnancy, and gave them 4,000 IU per day of vitamin D3 and saw that they achieved a serum 25-hydroxyvitamin D concentration of over 40 nanograms per milliliter. They'd actually started the study with 400, 2,000, and 4,000 IU per day, but found that those taking 400 and 2,000 IU per day did not achieve serum 25-hydroxyvitamin D levels high enough to be useful. And what they used as a criterion for beneficial effect here was most people getting their serum, their 125 dihydroxyvitamin D levels up to the optimal level. As they increased the 25-hydroxyvitamin D up to 40 nanograms, the 125 levels kept increasing. For most people, 125 is not related very closely to 25-hydroxyvitamin D. But for pregnant women, it is a very strong relationship. As I think I mentioned earlier, 125-dihydroxyvitamin D controls the expression of many genes, and you can imagine that a developing fetus is having to have the expression of genes in the development, and is looking for whatever signals it can to affect the gene expression. And so having proper vitamin D can really help in the outcome for the fetus as well as for the mother. So let's turn now to the evidence that vitamin D reduces the risk of many types of disease. There are many types of evidence, and unfortunately I didn't include the slides on types of evidence, but let me just talk about them briefly. Solar ultraviolet B radiation is a source of vitamin D for about 90% of our vitamin D. Our vitamin D rises in summer and declines in winter. What we get from diet is around 250 or 300 international units per day, which has very little effect. A person in the sun, midday, mid-latitude, summer sun, with full body exposure can make 10,000 to 15,000 international units per day. In England in summer, with a high latitude, 51, 52 degrees, even casual exposure for 45-year-old people in summer is enough to raise the serum level from, let's see, about 15 nanograms to about 30 nanograms per milliliter. So, so the point is that for many diseases, just where people live provides controls the amount of 25 vitamin D that they produce. And so by what are called ethologic studies, you can look at disease outcomes as a function of location versus the solar UVB dose I showed earlier and find out what the effect of vitamin D might be. The second type of study are called observational studies, and there are two types. One is the case control study, where somebody is diagnosed say, with cancer, and you measure the serum 25-hydroxyvitamin D at that time. There's also the cohort study, like the nurses' health study and the physician's follow-up study run by Harvard, where people are enrolled in a study and follow for 5, 10, 15, 20 years. They take the blood draw at the beginning, and then follow these people every 2 years. They give them a questionnaire: what are you eating? How are you feeling? Have another physical? What diseases do you have? And they will look for cancer, cardiovascular disease, and death, and so on for many years out. Unfortunately, they use the one value of vitamin D from the time they enroll in the study. And unfortunately, as people change lifestyle and age, the serum 25-hydroxyvitamin D level changes, and so that measurement loses importance as time proceeds. So you'll have the health system that doesn't like vitamin D, that wants to fight it. They will say, well, there's conflicting evidence from the case control studies and the cohort studies, and we think that maybe the disease state will affect the serum level at the time of diagnosis, so we're going to throw those out and just use the cohort studies, never mind the fact that we're using vitamin D measured 10 years ago. So there's a problem with the health people trying to figure out what's going on. There are also cross-sectional studies where they go around the country measuring people's biochemical markers and health status. And again, that can be used for finding relationships between vitamin D and health status. But that may be a little more likely to be affected by the disease state. If you're really sick, you're going to be staying indoors and you're going to probably have less vitamin D. Anyway, the types of disease with strong evidence include about 18 types of cancer, cardiovascular disease, including coronary heart disease, stroke, and congestive heart failure, diabetes mellitus, both types 1 and 2, respiratory infections, both viral, like influenza, and pneumonia. Influenza is largely seasonal. There are two reasons for that. One is when it's cold and the humidity is low, the virus can live better outside the body, and so it's more easy to be transmitted. But on the other hand, because solar UVB doses are low, serum 25-hydroxyvitamin D levels are low, and that's another risk factor. There was a randomized controlled trial in Japan with school children showing that the school children given 1,100 IU per day versus 200 IU per day who had not been taking vitamin D before the study had a 2/3 reduction in type A influenza compared to the control arm. Type B influenza was not affected. We've done another study looking back at the 1918-1919 pandemic influenza, and the Public Health Administration at that time went to 12 communities and did a door-to-door survey asking, did anybody in this household develop influenza, and if so, did they die? And it turns, this was in the case fatality rate, which is anywhere from about 1 to 4%. It turns out in the southern part of the country, the case fatality rate was more like 1.5%, whereas the northern part of the country was more like 3%. And what we hypothesized was that vitamin D reduced the cytokine storm, which the body's innate immune system is trying to put out a lot of cytokines to react to the infection, and that can then affect the lining of the lung, allowing the ever-present bacteria to take hold, get inside the epithelial lining, and cause pneumonia. But if vitamin D is there to reduce the cytokine storm and also fight the bacteria, it then reduced the risk of pneumonia. And the AH1N1 pneumonia influenza we had in 2009 was very similar to the pandemic influenza in 1918-1919. And as a result, many of the older people had antibodies to the to that type of influenza. Autoimmune diseases, multiple sclerosis, one of the ones for which vitamin D is well known to reduce the risk of, and of course falls and fractures. Here is the map of colon cancer mortality rate for 1970-1994 at the state economic area, with their 500 state economic areas. Now, Cedric Garland, who spoke at San Diego a year or two ago, and his brother Frank Garland, in 1974 saw the earlier maps like this, which only had 5 scales, 5 gradations. And of all the cancers, colon cancer was the only cancer that showed very high mortality rates, like in red here in the northeast, very low mortality rates in the southwest, shown in blue here. And they just driven from San Diego to Baltimore, and they knew it was very hot and sunny in San Diego and in Arizona, New Mexico, et cetera, and sort of cloudy and not so sunny up in Baltimore. So they hypothesized that solar UVB, by producing vitamin D, reduce the risk of colon cancer. They fingered vitamin D because they said that vitamin D production is the most important physiological effect on the body of ultraviolet radiation, of sunlight. And the black lines here are contours of annual solar radiation. Now here's the similar picture for breast cancer. You see it's similar, but in California, Oregon, and Washington, there's some additional red areas. Part of the thing is along the coast of California, even the coast of in western United States, you have the marine fog and clouds which obscure the UVB, and it turns out breast cancer is it's a very rapid growing cancer, and it's more sensitive to vitamin D at the time. It's not slow growing like colon cancer that can just every summer gets a good dose of vitamin D, it can kill it. In fact, it turns out that melatonin reduces the risk of breast cancer. So breast cancer is most commonly diagnosed in spring and fall. In winter, with less sunlight, there's more melatonin. In summer, there's more UVB and more vitamin D and less breast cancer. Anyway, these studies can be used in ecological studies with solar UVB and other confounding factors such as smoking, alcohol consumption, urban residence, Hispanic heritage, and poverty to tease out what the effect of UVB and vitamin D is. Now, of course, the health system wants to see randomized controlled trials. There was one randomized controlled trial conducted by Bill and Laffey, Robert Heaney, and colleagues at Creighton University, reported in 2007. They had actually done a study on postmenopausal women, looked for the effects on bones, since they were mainly calcium bone people. But after they saw that UVB and vitamin D could also reduce the risk of cancer, they went back and analyzed the data. And they were actually giving 1,100 IU of vitamin D per day and 1,400 milligrams of calcium or placebo. And the 25 hydroxyvitamin D levels rose from about 29 nanograms to around 38 nanograms per milliliter. And in this study, the all cancer incidence between the ends of the first and fourth years for those taking vitamin D plus calcium was reduced by 77%. Here's their study, and you see we have the calcium plus vitamin D, you had about 1.5% develop cancer, whereas in the placebo arm you had about 6.5%. In the calcium-only arm you had about 4%, but the calcium arm was not statistically significant. You can argue about whether it's the vitamin D and calcium or vitamin D. Calcium does have beneficial effects in reducing the risk of cancer. So it's probably a combination of both calcium and vitamin D that gave this effect. There's one other study, that's a randomized controlled trial that showed an effect for cancer. That was the Women's Health Initiative study for women who were not taking personal vitamin D or calcium supplements prior to enrolling in the study. See, they were only taking 400 international units of vitamin D in that study. Compliance was poor, so it was maybe an effective 280 to 300 international units per day. which is going to have a very small effect on the risk of cancer. But for that small subpopulation of the study, there was a 10 to 20% reduction in all cancer incidence rates and breast and colorectal cancer. So there are two studies, but then, of course, the Food and Drug Administration, the NIH say, well, there's a flaw with this study, there's a flaw with that study, we're going to throw them out. And so they still don't accept the idea that vitamin D reduces the risk of cancer. So I've, in my analyses of the primarily ecological studies, have come up with this list of 18 types of cancers for which we can say that UVB and vitamin D seem to reduce the risk. These be the gastrointestinal cancers, colon, esophageal, gallbladder, gastric, pancreatic, and rectal, urinary cancers, bladder and kidney, other cancers, both lung and melanoma, male prostate cancer, female breast, cervical, endometrial, ovarian, and vulvar, blood, Hodgkin's, and non-Hodgkin's lymphoma. So that most of the cancers, there are a few we don't see an effect. Maybe it's there, maybe it's not. Now, the other most important cause of death in developed countries is cardiovascular disease. Several observational studies have found that those with lower serum 25 vitamin D had higher risk of cardiovascular disease incidence or mortality rate. Here's one study from Austria and Germany, and they showed that there was a very strong difference between those in the high versus the low quartiles of vitamin D. They looked at the lowest quartile below about 15 nanograms versus those at higher values. You can't see this pooled analysis, but what I showed was up there in the curve. It was just condensed. What it appears is that if you go from 10 to 15 to 20 nanograms, you rapidly reduce your risk of cardiovascular disease. As you get out to 30 or 40 nanograms, we don't have much data above 40 nanograms, but about there it seems to slow down a bit. The mechanisms whereby vitamin D reduces the risk of cardiovascular disease are not that well known, but it appears that it has to do with inflammation. Cardiovascular disease does not have a geographical variation with respect to solar UVB dose, like cancer does. But it has a seasonal variation like influenza does. It's about a 15-20% higher risk of cardiovascular disease in winter than in summer, and that's when it's colder and when serum 25 vitamin D concentrations are lower. The only geographical variation I could find in the United States was related to the very small aerosols, which are called PM particle mass with diameter less than 2.5 microns. And these small particles get in the lungs, and they increase inflammation. There's also work presented here suggesting that nitric oxide is involved in reducing the risk of cardiovascular disease. I did the test with testing my oral bacteria and vitamin D for nitric oxide production, and I passed with high nitric oxide. So it could be that vitamin D, by reducing the pathogenic bacteria in the mouth and elsewhere, enable the good bacteria to produce the nitric oxide that's going to lower blood pressure and reduce inflammation and whatever. So unfortunately, the randomized controlled trials looking at reduced risk of cardiovascular disease have not been successful. They have not shown an effect. But maybe they're not looking at the right thing, or maybe working people have too much vitamin D. The other thing to look at is calcified arteries. And I think vitamin D helps reduce the risk of arterial calcification by making sure the calcium stays in the bones and not in the soft tissues. So more work needs to be done on that, but it does appear that vitamin D does reduce the risk of cardiovascular disease. Here's a study from Harvard, I think, the Nurses' Health Study. It showed that those taking more than 1,200 milligrams of calcium versus less than 500 milligrams of calcium, and more than 800 international units of vitamin D per day versus less than 400 IU per day, had 1/3 reduction in diabetes compared to those the controls. There are other studies showing that vitamin D does reduce the risk of diabetes. Autoimmune diseases, there's effects shown especially for, it appears that viral infections early in life increase the risk of asthma, type 1 diabetes, multiple sclerosis. And so part of the effect of vitamin D reducing the risk of autoimmune diseases is to reduce the risk of viral infections. But another part of the effect of vitamin D reducing the risk of autoimmune diseases is shifting the cytokine production from the T helper 1 pro-inflammatory cytokines to the T helper 2 non-inflammatory cytokines. Here's a chart put together by Cedric Garland of the horizontal axis. The black line is at 25 nanograms per milliliter. The color, it goes up to 68 on the right and down to 6 on the left. Now, on the lower left, you have the blue line, which is for rickets. So rickets is prevented if you have serum levels below about 20 nanograms per milliliter. African Americans, turns out, have on average 16 nanograms per milliliter. Hispanic Americans, 21 nanograms. And white Americans around 25, 26 nanograms. So white Americans are just above the dark black line. But you see that for disease reduction, you want to be above 30 to 40 or more nanograms per milliliter, which is going to take somewhere around 1,000 to 4,000 international units per day in the absence of being outdoors every day. The conversion from vitamin D to 25-hydroxyvitamin D decreases as one has higher serum 25-hydroxyvitamin D levels. If you start at very, very low serum levels, taking 1,000 IU per day will increase the serum level by about 12 nanograms. So when you get up to around 40 nanograms, you're going to increase by 6 or 7 nanograms. You get up to 100 nanograms, you're going to increase by 1 or 2 nanograms per milliliter. The Grassroots Health Organization has had over 3,000 people take vitamin D, serum 25-hydroxyvitamin D measurements and report how much vitamin D they're taking. They use VRT labs in Oregon, and it's a kit. You send in money, they send you a kit with a lance to draw 2 or 3 drops of blood on a piece of paper, send it back to San Diego, then sent to Oregon. They use a gas chromatograph mass spectrometer and measure the serum 25-hydroxyvitamin D. They can measure both D2 and D3. I compared values once with Quest and LabCorp, and the 3 values came out 65, 67, and 69 nanograms per milliliter, meaning that all tests, commercial tests now are pretty accurate. So what this shows is that for any oral intake, there's you can have a large range of serum 25-hydroxyvitamin D concentrations, or for any serum concentration, you don't know how much the person is taking in. There's just a lot of variability depending on where they live, their skin pigmentation, how much time spent out of doors, how big they are, how old they are, what their digestive tract is like, whether they're taking statins, because some statins will actually increase serum 25-hydroxyvitamin D levels. Inflammation will reduce it, air pollution will reduce it. So I guess the bottom line is it's worthwhile to measure serum 25-hydroxyvitamin D concentrations if you want to try to reach a given 25-hydroxyvitamin D concentration. Now, I did calculations for several regions of the world, including the United States, asking what would happen if the mean serum 25-hydroxyvitamin D concentration were essentially doubled from around 20 to 25 to 42 nanograms per milliliter. And for the United States, I've taken here, looked at cardiovascular disease, cancer, diabetes, lower respiratory infections, sepsis or septicemia, hip fractures, tuberculosis, and put in my estimate of the reduction by increasing 25-hydroxyvitamin D levels. And for the most part, for these diseases, my estimate is that you can get about anywhere from a 10 to a 30% reduction in the disease rate by raising serum 25-hydroxyvitamin D concentration. And so this would reduce if you have about 2.4 million deaths per year, 400,000 of these deaths can be considered premature. Now, people are going to die, but they're going to die on average about 2 years later. So you're going to get about a 2-year increase in the average life expectancy of a country by raising the serum 25-hydroxyvitamin D concentration, according to these estimates. And in fact, there are now 12 studies, at least 12 or 13 studies, looking at serum 25-hydroxyvitamin Ds and then following people for up to 12 years. And when they do a meta-analysis, when they average the results from all these studies, they find that the comparing, I think, highest versus lowest quantile, so say comparing above 30 nanograms versus less than 15 nanograms, they get on average an 8% reduction in all-cause mortality rate. What I've done is I've said, okay, I know that the serum 25-hydroxyvitamin D that you measure at the time of the diagnosis, enrollment, is not going to stay fixed, and it's going to change. So what if I plot the mortality rate, the hazard ratio, the odds ratio of dying versus the follow-up time that they used in the study? And that goes out to about 14 years, and about the minimum one is about 7 years. So if I draw a line through those data points and extrapolate to 0, I find a 28% reduction in all-cause mortality rate for low versus high versus low serum 25-hydroxyvitamin D. And that's consistent with this. This is 17%, that's 28%. I mean, it's in the same ballpark. As you go through the shorter follow-up time, the uncertainty increases, but I think the accuracy of the interpretation increases by going to shorter time. So what about serum 25-hydroxyvitamin D concentrations? The consensus of scientific understanding seems to be that you have deficiency in serum 25-hydroxyvitamin D levels for less than 20 nanograms per milliliter. You're insufficient in the range of 20 to 32 nanograms. The gray area is almost sufficient, 32 to 40 nanograms. Optimal in the range of 40 to 80 nanograms. What's normal in stunted countries is 54 to 90 nanograms, and vitamin D excess might be above 100 nanograms. So anywhere up to 100 nanograms, you're probably not going to have any adverse effects. There's a little bit of evidence, maybe of atrial fibrillation above 100 nanograms, although I'm not sure how accurate that is. There are some, if you read the literature, you might find that there are some studies suggesting a U-shaped relationship between 25-hydroxyvitamin D and health outcomes. There was one study on prostate cancer in Finland, which showed a U-shaped relationship. Both men in both the low and high compared to normal or average had an increased risk of prostate cancer. But that was a 17-year study, and in Nordic countries, they take a lot of cod liver oil to raise their vitamin D. Cod liver oil has vitamin A, and the retinol or vitamin A receptor is linked to the vitamin D receptor and can interfere. And they've actually shown for colorectal cancer that having more vitamin A interferes with the effect of vitamin D in reducing colorectal cancer. There are also some, you may have seen recently, an all-cause mortality rate study in Denmark showing a U-shaped relationship. Well, it turns out they knew nothing about the health conditions of the people involved, and I was able to point out that there were 2 studies in the United States looking at frailty of elderly people 4 years after measuring serum 25-hydroxyvitamin D concentration. For men, it was interesting. The higher the serum 25-hydroxyvitamin D, the lower the frailty in it, the healthier they were. For women, there was a U-shaped relationship. You got to the higher serum 25-hydroxyvitamin D concentrations, and they actually had the same frailty status as those in the low 25-hydroxyvitamin D concentration category. Well, in the United States, if you go to a doctor, if you're a woman over the age of 50, He's going to test for osteoporosis. If he finds osteoporosis, he's going to say, you've got to start taking vitamin D. Well, that's fine, except that's very good, but taking vitamin D after the age of 50 or 60 or 70 can't bring back the calcium in the bones that wasn't put in earlier. It can't reduce all the effects of low vitamin D earlier in life. And I think that explains some of these studies of finding a U-shaped relationship. Like I said, there are few risks of high vitamin D intake. Those with active tuberculosis, sarcoidosis, or whatever disease, such as lymphoma, can develop hypercalcemia at lower vitamin D intake, and so you've got to be cautious with them. And you want to measure the 25 to 125 in the calcium. The current upper limit, according to the Institute of Medicine, is 4,000 IU per day, but they noted no adverse effects have been noted for less than 10,000 IU per day. Sources of vitamin D are solar UVB, supplement, diet, and artificial UVB. There's nothing here. Now, back in 2009, the Food and Drug Administration, the National Institutes of Health, and Health Canada put $1 million into a study of vitamin D to develop new recommendations for the United States and Canada. Neither the FDA nor the NIH like vitamin D. In my opinion, they're doing what they can to discourage vitamin D. And they chose, here's the committee members down below. For the most part, these people were dietitians, some of whom had published in vitamin D, some had not. They had Tufts University has a group that does evidence-based medicine. And evidence-based medicine is primarily based on randomized controlled trials. I mean, they were considering vitamin D as a drug. And so they were looking for randomized controlled trials that showed that vitamin D was beneficial. Well, at the time of the study, the only randomized controlled trials that could find which showed a beneficial effect were for falls and fractures. And it turns out that those show you've got to have about 800 IU per day or more, yet the Institute of Medicine said, no, all you need is 600 IU per day of vitamin D and a serum level of 25 nanograms up to 70 years, or 800 IU per day for those above 70 years. And they only looked at observational studies and say, oh, look at the U-shaped curve, that's why you shouldn't go to higher vitamin D. I mean, they had a double standard. They could use the observational studies to discourage people from taking vitamin D, but they can only use randomized controlled trials for the beneficial effect. Since that time, we have the randomized controlled trials for influenza. Well, they had the one for cancer, but they didn't accept it. They said it was a flawed study. And now Joanne Manson, who is number 2 on the team, is the one that's hitting the VITAL study at Harvard, which is a 2,000 IU per day of vitamin D. Had the Institute of Medicine recommended 1,000 or 2,000 IU per day, that would have interfered with their study, because any guy in the study has to be able to take what the IOM recommended. So it seems like there may have been a conflict of interest in the recommendation, and also an institutional bias by the funders. Now, shortly after that, the Endocrine Society did their own recommendations. Michael Hollick headed this organization, this committee. He and Robert Heaney were on the 1997 Institute of Medicine committee that recommended, I think, 200 IU per day. But in 1997, all they were looking at was calcium effects. They didn't know about cancer, cardiovascular disease, infectious disease, and so on. But these people, these proponents of vitamin D, were kept off the ILM committee in 2009. So they went off to the Endocrine Society and made their own recommendations, recommending 1,500 to 2,000 IU per day and serum 25 hydroxy vitamin D concentration to above 30 nanograms. However, they did say that treatment with either vitamin D2 or vitamin D3 was recommended for deficient patients. At the present time, there is not sufficient evidence to recommend screening individuals who are not at risk of deficiency or to prescribe vitamin D to attain the non-salthemic effects for cardiovascular protection. But there's been a debate going on in the literature. The Institute of Medicine people critiqued the Endocrine Society study The Endocrine Society study then critiqued the critique, and it's an interesting debate going on in literature. If you want to go to PubMed, you can find these papers. Grassroots Health, led by Carol Baggerly and with Cedric Garland and Robert Heaney, very active in it. They called for a standard, this was about 2 years ago, or 3 years ago, called for a standard vitamin intake of 2,000 IU per day and achievement of serum level of 40 to 60 nanograms per milliliter. So in conclusion, there is reasonable evidence that low serum 25-hydroxyvitamin is a risk factor of periodontal disease and dental caries. There is reasonable evidence that low serum 25-hydroxyvitamin D concentration explains some of the link between periodontal disease and systemic or infectious diseases. Dentists and allies could perform an important service to the patients if, when they discover periodontal disease, they inform their patient that low serum 25-hydroxyvitamin D concentration could be an important risk factor, not only for the periodontal disease, but for the systemic and infectious diseases, and urge them to get their serum 25-hydroxyvitamin D levels measured and take measures to increase it to above at least 30 to 40 nanograms per milliliter. Thank you.